Okay, good morning. It's very nice to be back in Amsterdam. I spent 6 months working at the OLVG with Ferdinand in 1996. Ferdinand won't remember it because he's not really interested in football, but that was the year of the European Championships in Britain, and the English national team beat the Dutch team 4-1. I remember it very well. So, I'm going to start off talking about something that's perhaps fundamental to downsizing, which is that radialists, as we all know, are better operators than femoral operators. And I'm going to show you some of the data that supports that. It's a very serious world. We have to start off by openly and honestly declaring our conflicts of interest. Here's mine. This is the trophy room in Liverpool Football Club. This is the 2005 Champions League trophy. My colleague here from Italy will remember the game where that was won, memorably from being 3-0 down at half time. So, benefits of radial access, we all know this data, the prevention of bleeding and access site complications, issues of patient preference, institutional efficiency, cost saving, and in my opinion, being a radial operator improves the operator performance, and I will show you some data to support that. Femoral operators are used to working in this environment, and I've had to familiarise myself with the femoral artery once again as I've moved into doing TAVI procedures. And we still do our procedures through open incisions, and the femoral artery is a gigantic, huge, humongous great artery. Multiple millimetres in diameter. The route from the puncture site to the heart is a straight line. There's very little anatomical variation. And most femoral operators will work with only 2 guide catheters, a Judkins right and a Judkins left. So it's generally a technically undemanding and simple environment to work in. This is the neuroanatomy of the wrist, and the radial artery here, as we know, has a number of advantages. It's superficial, it's easy to compress, and there's a dual blood supply to the hand, but the radial artery is relatively small. It's between 2 and 3 millimetres, so it's not as easy to puncture the radial artery as it is to puncture the femoral artery. We've all been familiar with these kind of episodes of spasm in the past. When you cannulate and work in such a small artery, it's easy to trigger these kind of episodes, perhaps supporting the drive towards downsizing. Everybody will have seen these radial loops and other types of anatomical variations, such as this typical appearance of a retroesophageal subclavian. And we're familiar with the fact, if you look on the left here, that a Judkins right 4 deployed from the right arm in the right coronary artery has very little conventional support because it floats freely around in the ascending aorta, and you need to use more advanced guide catheter techniques, choosing perhaps an Amplatz configuration which is twice as supportive as a Judkins right. And radial operators will typically use deep intubation manoeuvres either with the guiding catheter or with guide catheter extender systems. So the radial environment is one of a small caliber vessel which is at risk of spasm, particularly when you use large caliber equipment. There's quite a lot of anatomical variation. There's a requirement to use advanced guiding catheter techniques, and so skilled high volume radialists are highly proficient interventionists. And it's not just the operator who is part of that. Their teams are usually motivated and highly skilled. The nurses, the cath lab technicians, the nurses who care for the patients afterwards tend to be a different kind of group of people than old-style femoral operators. And I will, again, show you some data relating to that. So how can we investigate the performance of radialists in clinical practice? Well, there is obviously now a wealth of randomized trial that supports superior results for radial operators. Of course, that's usually obtained in the environment of highly proficient radial operators, highly selected patients, and so it's subject to the criticism that it doesn't really relate to real-world practice. In the UK, the British Cardiovascular Intervention Society was established nearly 30 years ago to promote and monitor activity in angioplasty in the country. It collects data on all the angioplasties performed in the UK via a central electronic database, and each procedure has 113 patient, procedural and outcome variables that are recorded electronically and submitted. There is 100% robust mortality data on these patients obtained using a unique specific NHS number which is linked to a central register, and is a legal requirement in the UK to register every death and associate it with that number. So we have 100% mortality follow-up for our angioplasty patients. This is what's happened to angioplasty access site practice in the UK. It took, I started to run courses in 1999, and it took 5 years to get to 10%, but there's been an amazing change in national practice over less than 10 years. It's gone from 10% to 65%, and in 2014 we're probably running at close to 70-75%. There's no sign that this is going to slow down in any way. It continues to change and grow at the rate of 5, 8, 9% every year. And so collecting data on angioplasties performed in the UK is a useful way of investigating performance in the real world. This slide shows the volume of radial procedures in the vertical axis and the number of angioplasties performed in the centre. And you can see that UK angioplasty is increasingly concentrated. Around 2/3 now of all the centres are doing more than 50% of their cases transradially. And there are some very high volume centres out here doing more than 2,000 angioplasties a year and having a very high radial penetration rate. And if you look at the operators, you see the same pattern. Majority of operators now have moved into at least 50% of their practice being radial, but you do see down here some diehards who absolutely refuse to change their practice. One person here, I will find out who this person is, performing around 500 angioplasties a year, all femorally. You can't change some people. So, evaluation of radialist angioplasty practice in the UK. So the data I will show you in the next few slides covers a 5-year period, 2006 to 2010. It's all the patients who had a single access site recorded as either radial or femoral access. And there were 111 hospitals in the country performing almost 350,000 angioplasty procedures over that time period, and we divided them into majority radial centres, in which more than 50% of the angioplasty was performed via radial access, and majority femoral procedures down this side, in which, sorry, there's a slight error on the slide, it is majority femoral procedures, in which the majority of the cases were done that way. So around 100,000 procedures done radially, with 240,000 procedures done femorally. And if you look more specifically in the radial dominant centres, 70% of the cases were radial, only 22% were radial in the femoral centres. Is radial access better than femoral access in the whole PCI cohort? Well, you can see on this slide here, the red bars are the majority radial hospitals, the default radial operators, and the blue bars are the majority femoral hospitals. And if you look at, on the right of the slide here, bleeding rates, vascular complications and MACE rates are all significantly reduced in the radial centres, and 30-day mortality is reduced by around 30 to 40%. This isn't just radial procedures, it's just the radial dominant centres. There are still some femoral procedures performed in there, and if you look just at the radial cases, these differences are even more obvious. So in 350,000 patients here, the results of the randomised trials are very clearly replicated in clinical practice, even at a time when access site practice is changing so rapidly in the UK, and many of the operators are not particularly experienced. If you look at PCI outcomes by syndrome, here we have stable elective angioplasty in the top panel, unstable angina, non-STEMI angioplasty here in the middle panel, and STEMI angioplasty in the lower panel. The two bars here are bleeding and access site complications, and you can see that in all the syndromes, bleeding and access site complications are significantly and importantly reduced. And then if you look at mortality and MACE here in the stable patients, there's no significant reduction in the stable patients. But once you move into the unstable patients, and particularly the STEMI population, there's a clear-cut impact of radial access and perhaps the proficiency of the radial operators on mortality and MACE. And perhaps this relates to the fact that big bleeds are more important in these unstable patients than they are here. It's also true that stable angioplasty is so safe nowadays that it's difficult to really show a mortality benefit when those events are so rare. So once again, an almost exact replication of the randomised data that you see in studies like RIVAL, but in a very large population. And one thing that has been raised as being important in the UK by some people is that transfemoral procedures performed in radial centres may no longer be safe. And that's because the radial operators are performing fewer transfemoral procedures. They have reduced exposure to the technique, both in daily practice and for training, and there is reduced institutional experience with caring for femoral patients. Of course, you have to set that against a number of factors. When a radial operator has to perform a femoral procedure, when I do a femoral procedure, I am very careful with what I am doing, and I think most radial operators are like that. They commonly use fluoroscopic or ultrasound guidance to make sure they puncture the right part of the femoral artery. They do not use vascular closure devices. You know, what a kind of example of the triumph of marketing over facts, the use of vascular closure devices. Show no real benefit to patients, keeping a lot of North American countries in money, companies in money. And the other factor is that, as I've alluded to, radialists are simply better operators. If you can do procedures safely from the radial artery, you can certainly puncture a huge, great femoral artery and do the procedure well, in my opinion. If you look at our population and you look at the outcomes for femoral cases by institutional access site practice, once again, the red bars are the majority radial hospitals and the blue bars are the majority femoral hospitals. And if you look from the right here, you can see that bleeding rates, vascular complications and MACE rates are all identical in majority radial or majority femoral hospitals for femoral procedures. But if you look at 30-day mortality, there's a statistically significant reduction in mortality for femoral procedures performed in radial centres. So it tells you that radial operators, perhaps because they are very good operators, can perform femoral procedures even when they're done infrequently in their centres without any adverse consequences, and perhaps even with some benefits. Are radial centres and radial operators better at everything? Well, the answer to that obviously is yes. Here we have the femoral operators in red and the radial operators in blue. In majority femoral hospitals and majority radial hospitals, and we see that, as I pointed out, this is 30-day mortality, so it's 100% reliable. We have a significant reduction in mortality for femoral procedures done in the radial centres, and the radial operators are clearly better than these jokers, femoral operators, and they produce far better results for their radial procedures than the low-volume guys working in a femoral environment. So the BESIS database tells us that radial access benefits seen in randomised trials do translate into clinical practice. Radial centres seem to do better radial PCI than the femoral centres. There's no increase in femoral access site complication rates in radial centres, and in fact, femoral procedures performed in a radial centre were associated with an observed reduction in mortality at 30 days, and in multivariate analysis, this is of the order of 15% and is statistically significant. It's important to consider what the mechanism of these observed benefits are. We all know that these are not good things to get. Hematomas, sometimes they turn into one of these things. They become infected. The patient dies of sepsis, or spends 30 days on the ITU. Or they have one of these, a large retroperitoneal bleed. All of this is blood in the retroperitoneal space, compressing the bladder, pushing the bowel out of the way. It's not surprising that this is not a good thing to happen. And it's a specific complication of femoral access. But that is not the only mechanism by which benefit of radial access in practice is mediated. In the rival randomised trial, if you look at the STEMI population, there's a reduction in mortality, but there is no difference in their recorded bleeding rates using their trial definition in the two groups. So there must be some other mechanisms operating. And I'll show you briefly some data collected by my colleagues in Wales. It's a questionnaire-based observational study. It was answered by 204 UK interventional cardiologists. That's a third of the interventional cardiologists in the UK. And they answered questions on access site practice, antithrombotic strategies and operator characteristics. And the results were divided into default femoral operators, default radial operators, or what they called radial plus operators, which was radial operators who, if they failed in the right radial, would then use the left radial. Whereas the radial operators here would go to the femoral after a puncture failure. This is data relating to the age of the operators. So the femoral operators were significantly older than the radial operators. These guys were, on average, in their early 50s, and these guys were more likely to be in their early 40s. So these are old codgers, perhaps set in their ways, who do not like change. And these are the young guys coming through, who are perhaps more open to new ideas. If you look at clopidogrel use in non-STEMI angioplasty, The femoral operators are predominantly still using clopidogrel, but you can see that there's a change going on here with the radial operators. Less than half of them using clopidogrel. They've changed to newer antiplatelet regimes. And when you look at STEMI PCI, 50% of the femoral operators persist with clopidogrel, whereas 80% of the radial and radial plus operators have changed to newer agents of proven superiority compared to clopidogrel. So these guys are using prasugrel or ticagrelor, in line with international guidelines. Even more interesting is antithrombotic use in primary angioplasty. So here, the default femoral operators, almost 2/3 of them use a heparin-only strategy, no 2B3A, no contemporary antithrombotic strategies. And here, 20% or less of the radial operators using heparin alone, the majority of them using bivalirudin. So there's quite clear differences in the age structure of the operators and clear differences in other aspects of practice that are not directly related to the access site practice. The radial operators are younger. They're more likely to adopt modern antiplatelet and antithrombotic strategy. What does that tell us about the operators? I think it tells you that the radial operators are more open-minded. They are more up-to-date with contemporary practice. And they're more likely to change what they're doing and institute new therapies. And so the benefits that you see in the statistical analysis of radial outcomes are not just from bleeding prevention. It's because, firstly, they're better operators, they're more technically proficient. And secondly, they're changing other things that they do. And their cath lab teams are better also. Their nurses are perhaps still more welcome and more part of the team. There are many factors related to these data that are driving the differences that we see. So there are some limitations in this data. It's observational. There are obviously unmeasured confounders. You can partially correct for a lot of things by multivariate analysis, but not by things you can't measure. And the data was collected in an evolutionary period when there was rapid change in UK practice, but that would tend to negate the benefits that you would see rather than accentuate them. So in conclusion, radial centres do better transfemoral PCI. Radial centres do better radial PCI, and obviously, it's quite clear, radial centres do better angioplasty overall. And the radialists are definitely better operators. They have superior technical skills, they have an open mindset, and they're more likely to adopt evidence-based medicine at an earlier stage in practice. Thanks. Any questions? Do you want to do questions or need to?
I don't know if the cath lab is ready or not. If not, we have time for questions. Any questions for the audience?
A comment from...
No question. I'm a little bit astonished that radial operators use more new anticoagulants as femoral operators. I can only speak from my clinic. I would like to do that too, and we are a radial center. We still use heparin because we cannot afford the new drugs. So my question is, why are the radial centers in the UK so much richer than the femoral centers?
Well, they're not richer, and Germany is one of the richest countries in the world, isn't it? But we have a national health service where things are not billed and accounted so stringently, and people are more likely to change what they do. It's easier to implement some of those changes in the UK healthcare environment as compared to the Dutch or perhaps the German healthcare environment. I think that's the answer.
Another comment is, especially in STEMI, if you follow and you believe in recommendation, guidelines, evidence-based medicine, you know that, for example, heparin in STEMI is a suboptimal treatment compared to bivalirudin, for example. And this is clearly documented after Arizanimab Uramax trial. And it's not only safe to use a bival or direct thrombin inhibitor, but it's also more effective because even without any bleeding at all, you have less deaths when you use a direct thrombin inhibitor in STEMI on top of radial access.
It was my comment. We're very close to the Joseph comment. In my center, we're still using heparin for a primary PCI. And as you can see, we are among the oldest of the radio operators here. So you have maybe two kinds of radio operators, the young one and the old one. But maybe there are other explanations than that. Maybe the skillness for the radio operator is beginning from the function. And with years, we move the rate of transradial approach from, for me, 50% in 95 to 98% today. So to do that, you have to deal with a lot of anatomical variations. And I think we are training our skillness also from the radial puncture to the heart. And this is the reason why, in my opinion, we are better operator. It's not only science, it's also, everyday skillness and crossing the anatomical difficulty and so on.
Yeah, Jim, not a comment, but a question. Since there's an increase of radial procedures, what are you doing currently with your fellows regarding the femoral puncture? I mean, that's one of the problems I have when I have a femoral case, because they can't go through the radial approach. It's usually a revolution in the cath lab is, oh my God, we're going to do a femoral approach. How do we do this? And some of my residents panic. So what do you do to counter that panic?
Well, I mean, you have to train operators in both access sites. So in the UK, all of the operators get training in transfemoral punctures. Many of them start with radial procedures at the same time as they start with femoral punctures. I mean, it might be more of an issue in the future as that radial rate rises even further over the 65-70% it's at now. But I mean, we do offer a training in femoral procedures in all the centres in the UK. If I have to, if a patient of mine has to have a femoral procedure, I go and do it myself. But then, like you, I was trained as a femoral operator initially, so it's a kind of different skill set than the people coming through.
The way we solve the problem is that we work a lot with interventional radiologists, and I have one of my colleagues who's a cardiologist and an interventional radiologist. He takes all the fellows for about 2 or 3 hours to explain how to do the puncture. He's got these slides, etc. And then when he has femoral procedures, he calls the fellows over.
Yeah, I mean, we run radial courses in the UK, and the basic introductory course on how to do radial procedure, we're going to change that this year. We're going to run a course on vascular access site practice, and we're going to include in that a session on how to do the perfect femoral procedure. So we're going to try and change some educational initiatives. I mean, I think the most interesting thing about that data is the stuff about antiplatelets and antithrombotic use, because it tells you something about the operators and the way they think about things.
Okay, it's time to move
Yeah,
to the next
Marcial, we have to interrupt this discussion because in the cath lab they are ready.